Welcome back, everybody. Today we're going to talk about hip and pelvis, so please open your PowerPoint on that subject, and we're going to go, of course, as usual, one slide at a time. If it's a pure anatomy, there is not much to explain, but if there is something which I feel like I should explain a little bit better, of course I will. So the first slide, just titled Pelvis, gives you the anatomy. Again, so all I want you to do is really take a look at those features, familiarize yourself with pelvis, because as we are going forward, we're going to talk about some of those features. So again, you're going to create that mental picture of what we are talking about. So let's go to the next slide. And again, this is the different view, or the lateral view of the pelvis. So again, you have a list of important features of the pelvis. So all I would like you to do is to kind of point where is what, so you can orient yourself to the anatomy. Let's go to the next slide. And this is posterior view of the same pelvis. So it's just different views on the same bones. So again, please just take a look and familiarize yourself where is what, especially the bigger, more important features of the pelvis. So let's skip to the next slide. Here we are. So you got femoral on pelvic hip rotation, and you can see that in sagittal plane, frontal plane, and horizontal plane, what's going on as we are moving our lower extremity. So the top left, of course, is flexion, then extension, abduction, adduction, internal and external rotations. So again, the bone which actually moves, the one which we're interested in, it's marked as red or painted red, and the ones we are not interested at this moment for the sake of this discussion are in gray color. I think that this is pretty much self-explanatory. It's a femoral on pelvic hip rotation. So as you can clearly see over here, it's an open kinematic chain. So let's go to the next slide. And here you have pelvic on femoral hip rotation. So basically you are performing the same task, but in different form. This time it's a closed kinematic chain. So again, you have sagittal, frontal, and horizontal planes, and you can clearly see flexion, extension, abduction, and adduction, and internal, external rotation without actually taking your foot off the ground. So that's gonna be that major difference. Open kinematic chain, you take the foot off the ground and you're moving that foot or that leg. With the closed kinematic chain, of course, the foot is firmly planted on the ground and you're moving the rest of the body, forcing that pelvis to rotate or behave the way you want in the closed kinematic chain. Okay, let's go to the next slide. Femur. So again, those are just anatomical features which I would like you to be familiar with, because some of them we are actually going to address later on during the lecture. So you got head of the femur, greater and lesser trochanter, neck of the femur, linea aspera, lateral and medial condyle. So I'm going to go to the next slide, and you have very nice pictures, drawings, where you can actually identify all of those features mentioned in the slide before on the list and find them on actual bone. And again, I strongly encourage you to do it for your own sake, so when we are discussing certain things, you have that mental picture, that map, and you know exactly what are we talking about and where this part which is discussed is in human body. So let's go to the next slide. Here we are, ligaments of the hip joint, right? So Iliofemoral, I'm gonna read first from the actual slide. Iliofemoral covers the hip joint anteriorly and superiorly. Pubofemoral ligament is anterior and inferior to the hip joint, and ischiofemoral ligament is posterior and inferior to the joint. So let's talk about iliofemoral just a little bit. So in full extension, it stretches the iliofemoral ligament. So full extension stretches that ligament. What does this mean? That means that if you're doing flexion, it's going to actually relax the iliofemoral ligament, so it protects your hip from over or hyper extension. This is one of the stronger ligaments in human body. So pubofemoral and ischiofemoral ligaments are thinner than iliofemoral, therefore slightly weaker, of course, and they blend together with the actual capsule of the joint to make that capsule or that joint stronger. And I think this is good enough for you to know about the ligaments of the hip for now. Let's go to the next slide. This one is very interesting, and I think it requires a little bit of explanation, so let's talk about it. So I'm going to start with picture A and then proceed to picture B and C. So what can we see? Those red dots and those black lines, right? So let's start from those red dots. The red dots represent the center of that particular part of the bone. So on the femur, you can clearly see the red dot represents the center of the ball or the head, and the acetabulum, when you find that center, it's also dotted. So in normal case, if a patient or you don't have any problems, those two dots should align just the way you see it on this drawing. So now there is an inclination, there is an angle of how the femur is actually positioned. So if you are drawing the imaginary line through the middle of the shaft of the femur, and that's the dotted line, and you measure the angle to that straight line, which represents the perfect middle of the neck and the head of the femur, just as you can see it on the picture A. That's normal, and if you measure that angle, it should be about 125 degrees. And again, couple of degrees this way or that wouldn't probably make much of a difference. After all, everybody is different. However, where it's more excessive, then we have a problem. So the middle picture, picture B, it's called coxa vara, because the angle is significantly less. So from 125 degrees, it dropped to 105. So what does this mean? Where those dots are, you can clearly see that those red dots do not align anymore. So the hip, that represents that the hip is misaligned. Let's take a look at the picture C from the to the right hand side. Those red dots are misaligned. They are not aligned the way it should be, but this time the angle is much greater. Should be 125 degrees, but in this case it's 140. Now, one of this number is normal, the other and therefore should not be significantly changed. And of course I'm referring to 125. If you have 127, perhaps there is not a problem. If you have 122, perhaps there is not a problem. But 105 is arbitrarily chosen number. Could be 100, could be 90, could be 80. And in coxa valga case could be 138 or 150. So those numbers are chosen arbitrarily by the authors of the book, and just to underline the importance of the issue rather than focus on the numbers. So if you know that 125 is normal, then you know that any significant deviation from that number would be abnormal. So biomechanically, what does this mean to you or your patient? Well, a person can have negative or positive effects for either coxa vara or coxa valga. So let's take into consideration first coxa vara. The positive, the things which you actually have better is this alignment may improve your stability. So you are more stable in the standing position, for example. But that will cost you. So the negative effects are decreased functional length of the hip abductor muscles. So you're gaining stability, but you're losing mobility. I don't think it's worth it. So it's always preferable to stay in normal range. Okay, let's talk about coxa valga. We also have positive and negative effects. So positive effect is increased functional length of the hip abductor muscles. Therefore, you're going to have a more range of motions, or the muscles are not going to stay on your way if you want to have that range of motion. But again, doesn't come cheap. The negative is that you are going to lose stability. Therefore, your hip is going to be more prone for dislocations, and you don't want that. So let's go to the next slide. And everything what I just said you have on those slides. Positive effects, negative effects of coxa vara. The next slide, effects of coxa valga, positive and negative as well. So let's go to the next slide. And what we have over here is we're gonna take another look at the hip, but this time from the superior point of view. And there is another angulation. So we are of course talking about the same joint, the same bones, and on the left hand side, picture A, let's start from that. Again, you got those red dots placed in the same places you saw from the anterior point of view a couple of slides before. And you got this straight line drawn through those red points, as well as the middle of the head of the femur and the neck of the femur. And the dotted line is perfectly perpendicular line to the body. So the inclination, that angle was measured, and it should be about 15 degrees. Again, 15 degrees is not a large number, so perhaps deviation few degrees this way or that way would make a difference, but deviation of maybe 1 or 2 would not. And again, we have conditions, and you can see them in picture B and C. So excessive antiversion or retroversion, right? So excessive antiversion is when the number is actually bigger than 15. So let's say starts from 20. So everything above 20 potentially is going to cause problems. It's a misalignment or the joint again. So in this case, authors arbitrarily chose the number 35 degrees, and that's what you can see on the drawing. And the drawing C, the retroversion, is the other way around. The hip is also misaligned, but this time the number went down to only 5. Could be 7, could be 2. So again, this is an arbitrary number, but just showing you the problem, right? So how people try to fix the problem themselves, and a lot of time you can observe this on the street, for example, when you look at people, and we discussed this already, by posture, by the line of gravity, observing the line of gravity. If you know what to look for, you can say a lot about the general health of the person. How they look. Do they look healthy? Do they keep themselves nice and straight? or do they walk wobbly? Do they guard certain parts of the body? Is the walking pattern or the gait somehow irregular or negatively affected by something? So not even knowing the medical history of anybody or somebody, just by observation you can make a lot of solid good assumptions. Although the word assumption it has some negative negativity in it by itself, but in our case, similarly to the word stereotypically, it's not a bad thing. So pay attention that in order for, if somebody suffers from excessive anteversion and those dots are misaligned, and you can clearly see on this picture the authors chose to give us the number 35 degrees. So what the person needs to do in order to fix this, at least temporarily, is put the foot with the toes pointed inside, as you can see on this drawing on the right hand side, and you can clearly see that the red dots came back to the normal alignment. So the walking pattern is going to be different. It's not going to be perfect, but the person who decides to put that foot inside, it's going to suffer from less pain, at least less hip pain during ambulation. Okay, let's go to the next slide. Okay, this is very same idea. The only difference is here that you can actually check for the integrity of the pelvis bone. In this case, you're going to lay down your patient supine and ask the patient for pain, and then move patient's foot inside, as you can see on the picture on the right hand side, and if this alleviates pain in the hip area or it does not. And if it does, you know that the alignment of the bones is off. Okay, let's go to the next slide. Similarly, this is just talking about the retroversion, but everything what I just said, it's still valid, and you can address retroversion in exactly the same way. Of course, the foot this time has to go outside to align those red dots back to normal. Okay, let's go to next slide. Hip flexors, those are again muscles. Iliopsoas consists of psoas major and iliacus, rectus femoris, tensor fascia latae, sartorius and pectoneus. And we talk about the importance of the hip flexors, especially if somebody has low back pains or problems, sciatic nerve problems, etc. Those muscles are usually affected. They contract, causing a lot of discomfort, pain, and sometimes this awkward gait as people walk. Alright, let's go to the next slide. Hip extensors. Again, you have a set of muscles, which is always good to have this visual map as we talk about motion and human body. Let's go to the next slide. Hip abductors, gluteus medius, gluteus minimus. Gluteus medius is especially important for us because weakness of that muscle will affect the gait or the walking pattern, but we will talk about that in future videos, or even maybe later during this PowerPoint presentation. Tensor fascia latae, with explanation what is responsible for. There is not much I can say except what you can see on the screen. Hip adductors, again, this is the set of muscle or the list of muscles responsible for this particular action. Hip external rotators, same thing over here. Sartorius, what sartorius does in our body. Hip internal rotators, hip muscles, anterior view of all of those muscles put together from the anterior side. Posterior view, again, the muscles you had on the list. This is just how does it look in human body. Change in action. So this is interesting because some muscles do actually more than one action depending on the position of our body parts. So it's kind of interesting concept. So you got a short list of couple of muscles here: gluteus medius and tensor fascia latae. Leverage for internal rotation actually increases with the hip flexion. So the more you flex your hip, the more gluteus medius and tensor fascia latae actually improves your internal rotation. Pisiformis, external rotation when hip is extended, but interestingly does internal rotation when the hip is flexed. So that's what we mean by change in action. Depending where your body parts are, the muscle can do one thing or the other. Hip adductors, hip flexors when the hip is extended, or hip extensors when the hip is flexed. So that's very interesting, isn't it? Okay, so let's go to the next slide. Okay, here we have femoral and obturator nerves. Okay, so of course lumbar plexus, all of those major nerves supplying our lower extremities are coming from lumbar plexus, and you got L2, L3, L4 level. So if somebody suffers from low back pain and let's say have herniated disc at that level, the pain usually shoots through the buttocks and goes down to the leg. And the rule of thumb is that the lower the pain shoots, the worse the condition of the damaged disc and the more compression on those nerves. Anyway, this particular drawing is just represents innervation of muscles, and you got examples of muscles innervated by femoral and obturator nerve. And of course, like I just mentioned, the obturator and femoral nerve are coming from the same plexus, which is known as a lumbar plexus. Okay? Okay. Well, if you look closely at the muscles, those nerves or those separate branches actually innervate, you can recognize that the femoral nerve, the one presented on the left hand side, innervates hip flexors and knee extensors, when at the same time the obturator nerve, the one which you can see on the right hand side, innervates hip adductor muscles. All right, but which muscles? You have those muscles actually listed on that picture. So let's go to the next slide. And we have the sciatic nerve. Okay, probably everybody heard about sciatic nerve and the problems many people have with it. So I'm gonna give you some basic information about sciatic nerve here. So the sciatic nerve is the widest and the longest nerve in human body. It derives from sacral plexus, which is located on the posterior wall of the pelvis and is formed from the ventral rami from L4 to S3. So again, if somebody has damaged disc at low lumbar area, those damaged disc, the herniated or sometimes even bulging disc, can actually compromise sciatic nerve. Most nerves from this plexus exit the pelvis via the greater sciatic foramen. This is the big opening when you can see those nerves coming out. Sciatic nerves consist really of two nerves, and pay attention to the drawing, it's kind of misleading because the authors chose to use a red color, and then right next to it is a white color. But in reality, sciatic nerve is an umbrella name for two nerves, and you can see that they are kind of like bunched together and exit the pelvis together. Okay, so it's really two nerves. So one is called tibial and the other is called common peroneal nerve. So tibial and common peroneal nerve. And what can we do over here? What can we see over here also? That common peroneal nerve and tibial nerve go together up to the knee level, and right above the knee they're gonna split. They're gonna split when the tibial nerve is gonna go towards anterior side of your lower part of your leg, and common peroneal nerve stays behind. Okay, let's take switch the slides. Okay. Abnormalities. Again, you probably get used to that already. We talk about kinesiology or biomechanics, and then we talk about some problems. So here, some chosen problems are leg length discrepancy, hip abductor muscle weakness. We're gonna talk about Trendelenburg gait and gluteus medius limp, arthritis, and fractures. Okay, so let's go to the next slide. And on this picture we can see, we can measure our patients for the length of the extremities. So what are we going to, how are we going to measure? From the anterior superior iliac spine of the pelvis bone, anterior superior iliac spine, to the malleolus. We got lateral malleolus and we got medial malleolus. We actually are using middle malleolus, the one which is positioned inside your foot. Malleolus is the ankle bone, right? We popularly call it ankle or ankle bone, right? So on the median side is going to be the one which we're going to use for the measurement. So we measure it, and what do we know? Well, we know that the one lower extremity is longer than the other. That's it. That's all we know. So now we have to be a little bit more specific and measure really and find out why the lower extremity is longer than the other. So let's switch to the next slide. And we are laying down our patient supine and asking to put feet together and flex knees. So now you have two different points of view, right? So you can view this patient from the side or from up front, as you can see in the drawing A. So in the drawing A, clearly there is discrepancy in length of tibia. On the left hand side the tibia is longer than on the right hand side. You know now why the lower extremity one is longer than the other. But on the picture B, we can take a look also at the knees, and if they do not align, well, perhaps one femur is longer than the other. So in this case, in picture B, we have difference in length of femur. Now you can ask if a person can have tibia and femur length discrepancy, and of course the answer is yes, absolutely, this is possible. So let's change the slide, and in this case what we can see that is actually the third option. The tibia and the femur could be the same length, but the person is limping not because the actual number of inches is different, but because of the pelvis misalignment. And I mentioned my pains from my lower back from many years ago, and the fact that I was limping. So if you measured my lower extremities, you would conclude that nothing is wrong because both of my lower extremities are the same length. However, I was limping. Why I was limping? Well, because my pelvis was misaligned. So one side of my pelvis was higher than the other, and of course the end result is that you're walking as one of your lower extremity would be shorter than the other. All right, let's go to the next slide. It's called Trendelenburg test. How can you test? For example, this is a test for weakness of the hip abductor muscles. For the weakness of abductor muscles, gluteus medius, for example, that's the primary mover. So therapist has client lift 1 foot off the ground. So all you're doing is you can practice this in front of the mirror. So stand in front of the mirror and lift 1 foot off the ground. If pelvis drops, automatically drops as you lift your foot up on the non-weight bearing side, that means that you have a positive sign of the test. That means that your abductor muscles are weak. And I trust that you don't have this problem. However, a lot of your patients might. So this is one of the tests to check the integrity of the muscle. Okay, let's go to the next slide. Gluteus medius limp. Person compensates for weakness of the gluteus medius, the muscle we were just explaining, which abducts hip, especially keeping pelvis level by laterally flexing to the weak side. So in order to contradict that funky movement, that motion, that gait, the patients with such a weak muscles that tend to flex their trunk, so they work through with the trunk as well. Okay, let's take into consideration another slide. So this is a repair for the hip fracture. And well, you can see two different cases of scenario. Those are two real x-rays. On the left hand side you can see the big rod with screws, and on the right hand side you can see only screws, right? So I'm gonna give you a couple of facts over here. About 20% of people who suffered hip fracture actually die within 1 year. About 80% of people over 65 sustain hip fractures, which is really scary, and most of them are females. The risk for hip fractures, of course, doubles after the age of 50. So that's scary too. So people age of 80, 90, it's a real high probability that left alone they will fall eventually, and if they do and break the hip, 80% of them die within 1 year. And that actually happened to a couple of my patients. It really did. Two major reasons, of course, for those fractures, falls and fractures, is age related. The older you get, the more fragile your bones and the worse balance. The gait changes with age. So people are more prone for falling, and osteoporosis. And if you combine increased risk of falls with osteoporosis, then of course what you got is hip fractures. So in this picture A and B, both of those pictures are or shows you how the hip can be fixed without actually hip replacement. So the picture A, of course, is more involved than picture B, and let's go to the last slide, I believe. This is the repair of the hip fracture again, but this time what you can see over here is total hip replacement. So what they do, they cut out a piece of femur, they replace it with the titanium part, they clean the acetabulum, they put like a layer of titanium around the acetabulum, so those parts not only fit together, but they don't necessarily create too much friction. And another picture, you can very clearly see the whole device, the total hip replacement or total hip arthroplasty. And this is the last of the picture. So I hope you enjoy it, and I will see you soon. Thank you for your attention. Bye for now.